from what I understand so far, it's gone very smoothly. And particularly want to thank the people in our department who've been part of the education process. I know I went out and did my orientation with Eric, and he did a great job. And Darren's been working on it for months, so thank you guys for the time you spent on it. This is meant to be really a town hall type presentation, so we will have the mics back there in the back for anybody that has a question or comment, but if you can use the mic, it makes it easier for the rest of us to hear and understand exactly what you want to ask about. But we want to be free-flowing. Please, everybody, feel free. I would assume to interrupt, Darren.
Yeah, absolutely.
Okay. But Darren's going to lead off, and then you guys go.
John's going to fix our screen again here. For some reason it keeps flopping off so you can't see anything.
Stick.
Yeah.
Okay.
We're still podium PC up here, right? Yeah. Well, you may want to stick around to make sure. So, I guess so far everybody knows how to log into the system. Is there anybody that does not know how to pull up the system at all?
I don't know why it's doing that. Duplicate. Multiple displays.
So it keeps turning. It's anesthesia's fault.
Yeah. It should stay.
All right, I'll try to keep it going with my moving the mouse. So, if you don't know how to log on, it's Easter. Well, I don't know what we're going to do with this. This is useless.
This is a great start.
It's a great start.
We may have to restart the computer.
Okay, you'll restart.
It's going to take a bit.
So,
Sorry.
I think overall it's been fairly smooth from a surgery standpoint. The biggest thing is just the OR schedule being extremely delayed.
Use this. Come on.
Okay.
We can't hear you.
So can you hear me now at all? Yes. Okay. So the biggest thing I think has been the OR board being extremely delayed. But that should get better, I think, with time and as everybody gets used to using the system. And so that should get where it's, operating pretty much as normal. As far as stuff from our office, I had a case Monday morning at 8 o'clock. The H&P faxed over from the office was in the system. It is a read-only file that they've scanned in, as we have talked about in our business meetings. And the interval button, so if you do an H&P through Epic, the add interval button to the H&P, like when you come over now and there's a stamp on the H&P that you sign to say that there's no changes to your history and physical, so you have to do the same thing electronically. And so for our H&Ps being faxed from the office, it's requiring us to add a separate note. So you're just going to add a note. And you can do it in that same section, but it doesn't pop up the same way as if you had made your H&P in Epic, where it asks you just to add an interval. So kind of know that.
What do you have to say on that?
So, I mean, it's still the same. Yeah. I think there's still the same amount of, H&P reviewed, no changes identified, or if there are changes, put those in there, sign that. And that should suffice from a medical legal standpoint, I think. And so you still have to do...
Type interval into the smart text box, and that'll bring up the standard interval note.
When you all are making comments, can you speak on the microphone here, because we can't
You
hear
still
you back
can't?
here.
Oh, okay.
If you search in the smart text box for interval, it'll bring up the interval note.
that like that? I-N-D, or how do you do that?
We're going to show you here.
Maybe.
Maybe.
Maybe. There are personalization labs that are going on in the Whitehall building pretty much all day. So I would take advantage of those for those that are using the Erlanger system pretty much all the time. That is really going to make your day-to-day using the system a lot easier. The things that you should look at personalizing are obviously, having some sort of standard signature. That would be one thing. Having a standard history and physical that you like to use if you're making those out. We have, as a department, come up with, for the residents, standard H&Ps and progress notes for almost all the services. We have a standard trauma H&P. Those, as of right now, can only be edited by just a few people. As a resident, you can save that as a different file and then use that template, but we don't really want you doing that. I don't want you editing those and then using your edited versions. I really want you using the versions that we've made, and if there are changes that need to be made to them, please come and talk to one of us so that we can make those in the templates that are already there rather than end up with 200 different versions. So we'll see if we can get it pulled up. For those of y'all that may have not logged in yet, it's Eastern Time Production Hyperspace Epic. If you go to an Erlanger computer and log on, this icon should be on the desktop. If for some reason it's not, you can go to this little arrow button down here, and you'll pull up a little thing called Citrix Receiver, which is a small little black icon with little white lines in it. It's the Citrix logo, and that you can pull up Epic through if it's not on the desktop. So just this little button down here.
One other quick note, on most computers in the hospital, there's a sticker on top of the monitor that has that workstation's name. And when you log into the actual Windows, the first login, please use that name. They've sent an email about that because if anybody uses TIC01, like most of us have done over the last 5 years, if you use it from another computer, you'll get kicked out. Whenever you're doing an Epic, will get deleted. So make sure you use the workstation login.
So once you put your username and password, you'll be brought to this department screen. And Steve can maybe help me with this. I can't tell that there's much difference as being logged in as BEH surgery as EPHS provider surgery. I think the environments look the same. I don't know if there's a difference.
In some cases, the one that
Use the microphone. Yes, thank you.
In general, it looks the same, but there are some situations where we've encountered differences where you may not have all the tools that you need if you don't log into the provider environment. I've not heard that from the surgery department, but some other departments have seen that. So in general, if log into one that says provider.
So once you select this once, it should auto-select it for you. If you go to this hourglass, you can change the environment that you're on. We can go and change it to provider surgery if you want to, Kevin. That's fine. I guess y'all prefer us to use this one, Steve?
Yes.
Okay. We hadn't gotten a good that's the first time I've gotten a good answer on that, so you said, okay. Sorry, Kevin. I didn't mean to blind you.
Yeah, thanks.
You only need one. No depth perception. Okay. And so once you log on here, it's going to kind of jump to your screen. When you have surgeries scheduled, it's going to pull them up on your schedule for all the Erlanger system. It should be set up so you can see it throughout the Erlanger system in Plaza at East. And so you can just click on these patients, and that will take you into their chart to start working on them as you see them. So let's go to this top one, and these are actual patients. So please kind of keep this as confidential as possible. So if you pull up this patient on the sidebar, this is what it should look like. You should have chart review, summary, notes, orders, pre-op consult, and post-op consult. For us, you're going to work primarily in the pre-op consult and the post-op box for the most part. And for a lot of you, if you're not making a lot of rounds, really most everything that you do will just be in those two tabs. When it pulls this up, the workflow kind of goes here on the sidebar. And really, if you just follow it from the top to the bottom, that will kind of make sure that you have everything that you need. So this person obviously is scheduled for a laparoscopic ventral hernia repair. Go and see if the H&P is in there. I'm not sure if it's in there yet. So you have associated documents. This is the document that is scanned from our office. So if you clicked on that, which you don't have to do, it should bring up the USA, and you can close it out. It should bring up the USA H&P. So if you made an H&P in Epic, there will be a button that says add an interval note. But what I've noticed on this is that to update this H&P, you actually have to create a note. And so if you just go to this create a note, even though it's in the right H&P tab, and I don't know if you want to change this, Steve, but this is how it is working for our office right now. Then you're going to write if you get a create a note, it's going to pop up a box for you to go ahead and add your interval statement.
Darren, why couldn't you just go with that and click on update H&P?
Well, this box is just, it's just showing you this is the update section, and the H&P here is signed.
I'm talking in your pre-op consult list.
You can, it's going to take you to this box,
Okay.
which I don't think you can do anything in. There's not an option to like add a note in that box. So what we have been doing, and if we need to change the workflow, Steve, or if something needs to change in the system, is we're creating a new note under Write H&P that is an interval note, just saying that this is an associated document that is scanned into the system and has been reviewed. So from our office, that's the workflow that has been happening thus far, and it seems to be okay. But if y'all need to change that, we can do that.
But you don't have a place where you can actually go read it?
Yeah, you can click it, and that will bring up the H&P from the office.
Okay. Oh, I'm sorry.
All right, and then we'll close that up. Yes.
We'll introduce Mike Williams, who's the principal trainer for this part of EPIC. So he's got some input for you.
The way that this should work at this point, when you update your HTTP, it should be an add interval button on the right-hand side.
Nobody is seeing that.
So, yeah, okay. So can we just click on the, go to notes right under update HTTP? Down a little bit.
Right here on the update H&P section.
Just go to notes. Right. So yeah, this is something that we probably have to take a look at. It should be an add interval button.
There should be. I turned a ticket in on that because this is the way it's been working from our office, since this is scanned in as a read-only PDF file and it's not a H&P that was made in EPIC.
So if it's an H&P made in EPIC, the button shows up then?
Yes.
Okay.
All right. Go back to pre-op consult. So you can then review your orders. Go to probably, let's see, go to the regular orders tab. They may not be in there, and get assigned and held. See if there's anything in there. No. So they haven't put the orders in for this patient that is having surgery on Friday. hopefully those will be in there by the time we get there in pre-op. That should be the case. It was the case on Monday that the orders were there. I think the only order that did not come across was an antibiotic order, and I had to enter that separately. And so if you want to do that, go to pre-op consult again.
Who put that in?
I put it in.
In the office?
No. So I sent the orders over from the office with antibiotics in. That goes to pre-op testing. And those orders are supposed to be entered at that point. The orders were there. The only thing that wasn't there was the antibiotic. And so I think they just missed putting the antibiotic in, and I had to enter that in when I updated the H&P. And you can do that on this tab. You just go to orders and enter what antibiotic you want. And that's what I did, just let anesthesia know that I had made that.
Well, now, do you have to direct who that order goes to?
It's because you're in the pre-op environment, it should direct it to the correct phase of care as being pre-op, and the anesthesia folks will see that and give that before roll time or before cut time.
So it would go to pre-op testing automatically?
It will go to, yeah, you're going to be doing this in pre-op. If the order's not there, you'll be doing it in pre-op.
Oh, but you said you put it in. I mean, I'm just trying to, can you do this in the office when we, okay.
I think they just missed it. So I haven't had another patient come through to see if the antibiotics are there, but they're supposed to be entering them when we fax our orders over. I just don't, I think they just missed it on that one, but if somebody else has had one that was there, mine was not there.
So the old situation of us having standard order sheets, like for many of us in particularly Plaza, and I would guess upstairs too, for standard cases we do, you're going to have to enter that on every single case.
No.
No?
Your workflow is not going to change.
Okay.
You'll still fill out the order set that you normally do on paper, and then that will get faxed over to the hospital, and they will enter that information, and it should be in Epic when you arrive in pre-op. On my situation, everything was in there but the antibiotic, and they just, I think, neglected to enter that in. Hopefully that won't be the case every time. I'm not sure. I don't know if because it was a medication, if they didn't enter it in because of that. I guess we'll just have to see how that's going to work. But you can add that in if you go over to the pre-op area and they say, well, don't have an order for an antibiotic. Do you want one before surgery? Obviously, the answer to that in most cases is yes. You can go to orders as you update the H&P and just enter your antibiotic choice there. So do you want to show them how to do that, Kevin? Just put ANSEF or something.
You do it, you go to the order tab or to the pre-op consult tab?
You can do it under the order tab. Yeah. So, and then you just click the, yeah. And they will, for ANSEF, you just click the dose, IV. It's going to be once. When you do that, at the bottom, there'll be a reason in surgical site as indication, and then that will give them the order for your ANSEF. So if you run into that issue, that's how to fix it. All right, you can close that out. Let's go to post-op if it'll let us. All right, so that's all you have to do pre-op to get your patient into the operating room. The orders should be there. If they're not, there will have to be orders entered. And that's a little bit to go through in this forum. So if that happens, you'll just call one of us and we'll try to help you take care of that. Yes?
We had an issue on Monday where the nurse couldn't find an order for a consent. Like there was nursing orders to verify that the informed consent was done and to verify that the anesthesia consent was done, but they couldn't find the order for the actual words that need to go on the consent. Are there suggestions about that?
when the orders get faxed over from the office, there should be a case request that has been added to that patient still in Epic. And under the case request box, when you go through that and fill that out, there is an area to put what you want your consent to say. If it is not there, they're going to default to whatever CPT code the case has been posted as. Is that what y'all ended up with, was a default CPT code wording? Pull up a case request order.
When we arrived to the patient, the yellow sheet had been filled out, and the yellow sheet had been signed by the patient, because the patient still has to physically sign the piece of paper, is my understanding. But the pre-op nurse could not find the order in the Epic system so that she could then verify that order for the operative permit with the yellow sheet.
Well, let me show you if you're posting from the hospital, and then we'll ask these guys over here how to remedy that after the fact.
Yeah, that's my question, because yesterday I went to the floor, saw a patient who was in PO, and I was trying to get a permit to put in something as simple as a perm cath.
Yep.
And the lady helping me could not figure out how to do it.
Yeah, I can show you how to do that pretty quickly here. So basically what you're going to do when you want to request an OR case is just go to case request. Case request operating room, accept. And so then you're going to enter all this. So you've got provider, which is obviously going to be you, Dr. Fisher, if you're doing it. Location, you're going to select where you want to do that. That's going to bring down a box of everything. This should look a little different, Kevin. I'm not sure why this. I thought locations had little tabs over and not a drop-down box. But anyway, so you'll, under the location, you'll. All right, so there you go. So then it pops up this box over here where you can select where you want to do that case. If you're doing it in the main OR, obviously this is going to be here. The other locations are there as well if you want to use those. You got Plaza, the GI lab, those kind of things. Procedure date, you're going to select whether that, if you're doing an inpatient, it's likely going to be either today or tomorrow. And you just change the date there, or you can click the Today button down there and it'll add the day's date, so you don't have to fool with that too much. Is the patient inpatient? And in this setting, it will be if you're doing this. Procedure CPT, you're just going to look for the procedure that you're wanting to do. That's going to be by CPT code.
Or by procedure, you can search for that.
Is that something you can do on the computer?
Yeah. Yeah, you'll search for it here. It'll pull up the CPT code, and then you'll add that. Just go to accept.
Try to make sure you
Just accept
expand
that.
those things so you actually read them.
Okay. And so that's going to bring a procedure description in. So if you do nothing, if you really don't do a whole lot else with this, you can go down.
Darren, it populated that, put in the lap chole because you had put in a CPT code when you scheduled the case. Is that why? Okay.
So if you do nothing else, my understanding is that's what's going to be on the permit. However, there is a box down here. You go down. That they have taken off. Well, there was a box down here. Comments? And then there was on the test patients, we had another box down here that had had a box for consent. I don't think it was labeled as consent, but it was procedure description per surgeon or something like that.
Probably just fill out
And you could fill it out, but you could add a comment here or change your. I don't know if it'll let you change your procedure. Will it let you change your procedure description? I guess it will. So you can change that, and they should put that on your permit. You know, the forms that we use for consent are not informed consent. They're a hospital form. And so there really needs to be something that you've put in the computer as risk and benefits were discussed with the patient, those kind of things. That's really your informed consent and what holds up from a medical legal standpoint. That piece of paper that we fill out is just something from a hospital standpoint. I think probably the push is going to come for the physicians to fill that form out and have the patient sign that.
What form are you talking about?
The consent form that you sign in pre-op now. That paper, that one-page paper that you sign.
I thought we were going to no paper.
So the consent forms are still paper because the patient has to sign them. So they still have to have something to sign. So you have to have a paper form as of now. There is a way to do that electronically, but I think probably from a hardware budgets standpoint, that has not been elected to do that yet. I mean, at some point it could be like, you know, you go to Best Buy and you sign your credit card on the screen. And that may happen, but for now, you still have that page consent form. So
but you are right, that page consent form really does not protect you from a liability standpoint. So where in the chart are you going to document that you explain the risk-benefit analysis for this patient?
I put it in my H&P.
I do too, but I mean,
And I put it in my operative note. I do both. I put it in my H&P and in my operative note. At the top of all my operative notes, you'll see a brief description that tells a little bit about.
Well, I thought you were saying there was another place for you to put that. So, I mean, I think most of us do that in the H&P or a consult note if you're going to take the patient to surgery, right?
I personally think that putting it in the operative note is lovely, but it's after the fact.
Yeah.
In the medical legal arena, that has no.
Yeah.
I don't think that'll stand up.
Yeah, I do both. I do my H&P in there. I think the best place probably is your H&P, and then. But anyway, I guess what I'm saying for this point as to what is on the actual permit, I think there's probably going to be a push from the hospital that be done by the physician. So in the chart currently, there is still a paper chart that exists for the patient. But all that's in it is going to be stickers, maybe face sheets, and consent forms for procedures and blood.
How do you get to that page right there? You on the order page before that?
Yeah, you just go to orders, and then when you click on orders over here, it's going to take you to your kind of work environment on the tab bar here.
Okay.
And you can just put in case request up here. I guess if you change case description, that was probably what they'll put on your permit. I can't guarantee you. The nurses are probably going to be looking all over the place for what to put on the permit.
Sunday there was a line for consent.
So where do you find that case request after you've done the request and that order is done? Is there a place where it shows under active orders?
It should be under orders and signed and held in the pre-op area. Now, after the fact, I guess my question to y'all is, if that gets sent over from our office, technically there should be a case request that is put in by pre-op testing. If that is not there, how then do we add verbiage in there for them to get a consent? There is an order for verify consent. But how do we get that in there? Do we need to put in a separate case request for that day, or is there something else we can do?
I think a good answer to that what I've seen in the past is from the pre-op and consult navigator, you know, when you first double click into the patient's chart, if you use an order set at that point, a pre-op order set, it gives you the case request, the consent, your meds, your orders. It'll pretty much line up everything.
Well, yeah, that's a good answer for Erlanger employed physician.
Right.
For us, our orders are on a paper form that we're checking and then faxing over to the hospital to enter in.
Dr. Hunt, I mean, I don't know if this would help, but our orders are under media. If you'll go under media, our faxed orders would be there with our consent that we've posted the case, if that will help in the future of what we faxed over. I don't know if Erlanger knows where to find it.
Yeah, I think the only thing is for them to actually do anything with that, it's going to have to be, it's going to have to still have put in the system by somebody.
And I think that's the part where if it's not done when you get there, then you're going to have to do it anyway.
Yeah, if it's not done when you get there, you're going to have to do it to get your case going. Orders. Hopefully the H&P will be there. I think if your H&P, hopefully we do not encounter that very much, but if you do.
I think it was day one, but I think I heard one of our doctors saying that they had 2 cases on Monday and neither H&P was there.
All right. One, I don't know if maybe they didn't know where to look for them. 2, I guess this is not probably the right answer, but the answer that I'm going to do is I'm going to put in an interval note that says H&P fax from our office should be entered into the Epic system under media tab, reviewed. There's no updates from my office, sign. That's what I'm going to do.
You can't just hammer out a H&P in 3 minutes like you used to do with old.
Nope. So that is going to be what I'm going to do, and hope that it gets scanned into the system, and you'll get a notification probably if it's not. But you're not going to be able to do a new H&P very quickly there.
Is there some way that we can?
That may not be the Epic answer.
Office when we know we're going to do the gallbladder next week and just do the H&P like on our laptop?
Yeah. So I think the Epic's loaded on. Are they on our computers up in the office now, Rodney? So they should be there. You can do that yourself if you want to. That's probably that's the ultimate push from Erlanger for us for us to do that.
I think that's the safest way, and then our office could just, I guess they'd have to print it out and scan it up into our EMR.
Yeah. So we can probably discuss that at some point.
You can also
what? I don't know.
I don't know about that.
Have an interface from Epic to our EMR to get that to happen?
If you have Epic on your computer, if you can get it up and you have your EMR up, just copy your H&P and place it in the pre-op and console area, H&P, and then it's in Epic. Just copy and paste it.
So I guess you could, I guess if you had med streaming pulled up through Citrix receiver on the computer that you're working on, and you pulled up the H&P from the office and copy and pasted it over, you could technically do that. That would be a pain in the rear. Yeah, but I mean, does everybody know how to get on to med streaming from Citrix receiver on your computer? All right, so that would be one problem. I think for now, like I said, that's what I'm going to do, and just go from there. I'm going to write an interval note basically and just say H&P was faxed over from the office.
You're going to write that into the Epic H&P.
Yeah, but would they roll without it?
Will they roll without it? That's the question.
I don't know. I haven't tried it yet.
We were told they would.
mean, they don't right now.
Gillian keeps raising her hand.
We had the wrong H&P faxed over, like the house I did, and she went on and printed off the right one, but they couldn't scan it in, so then I just typed it all into the H&P so that we could have an H&P.
Yeah.
Yeah, that's the
We're
question.
gonna try to avoid that if we can.
That's the question I have. I'll bring a printed off copy sometimes because a lot of mine don't show up. So I'll have the hard copy in my hand.
Yeah.
Does that do me any good at all to put it on the
I
chart?
have
with
asked
the
if there was
stickers
gonna be
or
a
something?
scanner in the pre-op area that they could scan into Epic, and I was told that that was not the case. Is that correct?
Somebody's got to be able
Let
to
me just
scan
suggest,
I think the answer for that is they can email it to you and you can paste from your email into Epic. You cannot show up with a piece of paper, won't do any good.
so that you could bring the H&P legitimately from your office. I mean, that's crazy not to have that.
That's an issue that I will take back and we'll get resolution.
I mean, that just indicates you don't want their business, it seems to me. Okay.
Oh, it's gonna be a work in progress. I mean, just because we're not interfaced with the system. I mean, I don't know the best answer to some of it.
It's not just us. It's not just us.
No, it's not just us.
I mean,
it's
there are
ENT
other
and
other
plastic.
doctors in this that still have privileges at Erlanger.
Absolutely.
You need to be able to at least scan something in if they've got a legitimate H&P.
I mean, I don't have a great answer for those questions other than we're just gonna have to figure it out. It's just.
Right now, what is the exact process, Melissa, when we have an H&P? Are we faxing it or?
Yes.
Dr. Valier's point about emailing it, somebody at Erlanger could cut it out of a email and paste it in there. Maybe that's a solution rather than scanning something.
Well, when you ask me about your case, I go to media and Epic, and then the orders are there and the H&P, and it's just like that scanned document you just, went in earlier, but it's our H&P.
But is it scanned or is it an actual electronic file?
No, it's scanned, because it's faxed to pre-testing, but their system is electronically, so then it's scanned into Epic.
I think you should get with Erlanger and see if it's a way you could email the
I'm gonna talk to this gentleman right after we finish.
electronic file, and then they can cut and paste like Dr. Valier just said.
That obviously makes sense, but we don't have that interface yet, I don't think.
If they have an Erlanger email address, they could email our file to that person, and then they could cut it out of the email and then paste it into Epic, and they could be the one worrying about the interface.
Close that out.
That's what Melissa needs to work on.
No, I mean, who's that person at Erlanger?
She can find out.
But she doesn't hire them.
That's a one-time thing. She finds out the email address of somebody that'll do that.
One of the problems I've had with the H&P that allegedly comes from the office, that has the USA letterhead at the top of it, is that most of mine don't have a lot of stuff in the physical exam area.
Okay.
It just has something very specific, because I do vascular, so it's going to have some comment about a pulse or something like that. So in the past, when I've tried to use that as the H&P, it's been rejected by medical records because it doesn't have enough physical exam. Now, it's my understanding that
That's true. You gotta put down chest clear, heart normal, a few basic things under the exam.
And your review system.
well, I haven't been doing that, but
That has to be in your H&P or in your interval note. You can put it in your interval note if it's not in your H&P. That's where you have to put it. That's what you've always had to do.
Right. But you've got to document that you did something other than, I mean, I have to do that, I always had to do that with the breast case. If it's been a year since you have documented that you listened to their heart and lungs, then you've got to document your
Consults. Make sure people are attaching their note and not writing ER. You have the rest of the state after this.
So we'll try to shore up that process a little better, and I'll get back with you at a business meeting to tell you about the H&P from our office, because there's going to be we need a little bit more time to see how this is going to work and see what we need to do. I don't think that's an answer we're going to have today. But let me show you just a few more things for people that round at least. Can you go to lists, Kevin? At least just show them how to get to a list. So you have patient lists. You should be shared with the appropriate patient list. If you're not, let me know and I can share you with it. We have an Erlanger East list now, so you can add patients to that Erlanger East list for the weekend rounding guys. It makes it a little easier.
How do you add a patient?
Kevin, you can show them how to do that. And these are shared patient lists that we've made. So we do have to share you with those. So if you're not on one of these lists that you want to be on, just let me know. I can add you to that.
Now, how did he add it?
He's working on it.
He's working on it.
You click the appropriate hospital in the available list tab. The best way is probably to go to units, find where the patient is located. So let's say, for example, the surgical ICU. Once you've found your patient, you can just drag and drop to the appropriate list. Yeah, if you want to search for them by name, you can use this search all admitted bar in the upper right-hand corner.
When you're searching for a patient, use this, under patient list, use this bar. If you go to patient lookup and look up patients that way, it pulls up a different way of viewing their entire chart and their entire history that is not very work-friendly. So try to use that bar.
How do you delete a patient from the list?
Yeah, you do have to delete them manually. They don't fall off after they've been discharged. You select your list, you find your patient, you right-click, and you select Remove Patient.
One of the other things as far as a workflow issue is for dictating your operative note. Most of you may know this already. You're going to be using a CSN number. The number that we used for dictations before was the accession number, typically started with a 11 something, 112, 119 number. So it's going to be a CSN number, and that is specific for their hospitalization. So this is the number you're going to be using. As of right now, that is still not on the stickers, right, Steve?
We're getting that fixed.
Okay. So if you work off your stickers, which I think most of us do, at least I keep a little book and put my stickers in for my procedures, that number is not on the sticker currently. Hopefully that will get fixed. As of right now, when you're doing your case, if you're using your sticker to put that, to dictate that later, make sure you write down that CSN number on your sticker. Yes.
Actually, you could dictate it under the medical record number, and it'll come on the same. It'll show up over there because I
haven't tried that yet.
I tried that, and
the instructions we had was just to use CSN, but
the other question, when you enter the dictation with the CSN number, it'll populate on that medical record number right for the coders to pull it. Because when we pass our billing and the MD coder, we're going to enter the medical record number.
yes, it'll still pull up. The medical record number will pull up their entire history.
So either one of those.
We've been told to use the CSN number. Is that correct?
Dictation.
For dictation?
So this is the equivalent of,
Yes.
in Vision, the patient ID that changed for each hospitalization or each encounter. The CSN.
Medical record number never changes, so it stays with the patient throughout their history of care. CSN changes for each encounter. So CSN is a more specific way of tying this particular operative note to this operative encounter. Does that make sense? So if you, yes.
What is that HAR number on the speakers?
The HAR? I'm not sure.
I think.
It is translation on the sticker, the old number.
So from what I've been told, this number changes based on what department they're in, and this is like an accounts receivable number to go to. And so that number will change multiple times in one hospitalization. So if you pull this number up when they're in pre-op or in the operating room, it will be different than if they're in an interventional radiology. from what I understand. And it's a way of, I think, divvying out stuff into different departments.
Can we still dictate from 3901?
Yes. That is interfaced into eChart, so those dictations will flow through. Some of you noticed that some of your dictations were delayed with Go Live. That should be fixed today. So if you're not seeing dictations interfaced in, please let me know.
All right. So I feel like for the most part, for the attending surgeons in the room, the H&P thing we'll have to kind of work on from our office standpoint, and also the orders, and we'll work on that and try to get that to work more seamless. From a hospital standpoint, getting patients on, obviously you've got residents here to kind of help you out, so that will be good. And then you know how to dictate at least your operative notes into the system and sort of how to navigate the pre and post-op stuff. The only other thing I guess that you're going to be doing on a routine basis is doing your medical records. And does everybody know how to do that? No. Okay. So you're going to have a mailbox tab up here at the top, and this is going to be all your medical records. There'll be, as you get different records, there'll be more things down through here. Chart completion, just click on that. So as of right now, all verbal orders are coming to the attending of record for you to sign. There's been some discussions about that. We can bring that up later. But your operative reports will be here to sign or co-sign as well. So if the resident dictated an operative note, it'll be there for you to sign, just like it was through physician's portal when you went in to do your medical records before. It's very similar.
But even if you change it in the future, for patients that have been done the last 2 days, the staff's going to have to sign it, right?
Ask your question again. I don't think I
Well, you
understand.
said that doing your medical records.
Yes.
If I had a case that I did Monday.
Yes.
And there are verbal orders put in by Brent.
Uh-huh.
Then if I don't sign it, then I've got an incomplete medical record.
Yeah. Yeah.
So I better just go ahead and sign it.
Yeah. Yeah.
Right?
Yeah.
Okay.
Yeah. I mean, it's best to sign those as quickly as possible, but you're going to, what we have seen so far is we are getting inundated out of these, because these are not verbal orders necessarily just from physicians. Like, this is an order for, a bedside commode, and I mean, I'm getting orders for diapers, jillion stuff.
So I was trying to order a chest x-ray this morning, like verbal order, getting the nurse to do it. But the problem, and we worked through it together, and it only went to the attending for any procedure or imaging. I can apparently only verbal order meds. Is that correct?
That's probably in the system. It's been built out that way for a bunch of different reasons. I think probably for, is it?
Yeah.
I've kind of figured it might have been built in there for tracking purposes, for seeing who's ordering what imaging studies.
So there is a configuration problem that was identified at Go Live where when a resident does a verbal order, sometimes it requests an attending's name, and that is not our intention of how the system should work. You should be able to do those without it having to go to an attending for co-signature. And that has to do with the restriction on who can be an authorizing provider, meaning a billing provider or the attending of record. So the team is going to go back and figure out a way to code that where a resident is not an authorizing provider in the sense that you can't bill under their name, but they are able to do verbal orders without requiring an attending co-signature. So we'll work through that one.
Steve, will you then, though, when the medical record is signed out, is that the final signing of it? Will the resident sign that out, or will the attending sign that out?
The resident should be capable of signing their verbal signatures.
All right. So hopefully some of this will go away. Yeah.
So there's a lot of patients showing up for me just to have information that I don't know who this patient was. They were seen in the emergency department and were discharged with constipation, and now my name shows up in the chart and they're somewhere in my in basket here. Are the ER doctors just randomly dropping providers' names on these patients for informational purposes, or how's that happening?
They're probably either routing you the document or they're adding you to the care team.
Why? And who's telling them to do that? No, I wasn't the attending on call.
So that would be a question that we should put to the people that are doing it. So one of the advantages of this system is the ability to communicate. And if one of your patients that you operated on 3 weeks ago is in the ER for a minor complaint, but they think you ought to know about it, they can send it to you without calling you. The downside of that is it's almost like email spam. You can get in a habit of, oh, I'll send it to everybody. And so that's one of those things as a medical staff we'll have to work through. And those that are sending lots of superfluous stuff, we just need to provide them feedback. Hey, I don't care that they had a hangnail.
Steve, along the same lines, I noticed in my inbox of patients list or associated, some patients that I don't know, that they came to me because they belong to somebody in the group, totally unknown to me, like a trauma patient. Then I put the list of providers that may have been associated with that, and even providers that are not here anymore, like Dr. Marco Chavarria. If you look it up, he's on the list of the surgeons there, so in our group. So there are things like that. I know it's work in progress, but there are some things that are showing up. And I know when that comes to HIPAA violations, I'm getting a lot of information on other people that I don't know about. I don't even know who they are. Some medical patients as well, admitted to the medical team for a totally unrelated problem, appears on my list with picture and everything. So I think something needs to be checked into that, because I've noticed that on my list. And I asked some of the instructors, and they didn't know how to fix it.
Some of it may be used.
Here, Bob.
It came in the results tab. I got one of my patients was 3 weeks out from something I had done and went to the emergency room. The note said because their incision was itching, and the ER doctor thought that they were pain med seeking, and they just sent me a little brief note about their encounter. So in some ways that can be helpful, I think, because I knew that patient was in the emergency room, and otherwise I wouldn't have.
So back to Dr. Vallier's question, please provide us feedback on those situations. One of the things that happened when we went to convert Envision to Epic is we found that there were more physicians in Envision than there are practicing in the Chattanooga area. In fact, there were thousands, and that's 20 years of accumulated stuff that hadn't been filtered through. So we do have some clinicians that we have built out. You know, we filter them as best we can, look and see who's had activities, but there are a number of them that have been built out in the system as inactive providers that aren't here. So if you see those, send them to us. We'll trim that list down.
One more thing about the communication, sorry. I also noticed that some of the outpatients Erlanger-based offices are sending the information to Epic, which is appropriate, but we are not getting it anymore like on a fax like we used to. So I picked up, even before we started live, so when I went live on the 29th, I came Sunday, I started looking at my messages. I have all kind of information building up for the last 2 weeks from outpatient offices from Erlanger system that I was not getting in my office at all. So I found it on the Epic, which is great, but we need to know what the process is going to be for those, because otherwise we may not get them in the office.
That's a great
That's
question.
what we used to. Including I don't know what's going to happen with the imaging also. I don't know.
So when you route a document, you can route a document to another person, another user within the system. So if I send you a gallbladder, you'd route it back to me within eChart. Because there's no point in generating a fax. On the other hand, let's say Ron Jarl in Hickson sends you a hernia repair. Well, you can, with just a couple clicks, send your note to him, and you can you can choose the method. So if he has an account, you can either send it directly as an inbox message, or you can send it as a fax. If he doesn't have an account, then you just have the choice of fax, or you could mail it. Does everybody know how to route a note or a document?
And you're talking in Epic though, right?
Right.
Yeah, well, we don't have Epic in the outpatient.
Right, but you can route to somebody that's not in it. It just goes by fax.
In our office, we don't have Epic.
Right.
So the chart wouldn't be in our office.
So I could route a document to you in your office via the fax machine.
But if we're in the office taking them in follow-up, we can't route them back out of the office. We don't have Epic in the office.
Right, you'd have to use med streaming.
But, so say we do the hernia repair, is there a way when we're in Epic dictating that chart or finalizing that chart to send it from Epic by fax?
Yes.
All right, that might be useful.
So we'll put together a tip sheet on how to do that and give it to you. Yes.
Just more for the residents.
So I'm doing my best.
Which notes that we do 100% need co-signatures and which ones don't? I know that H&Ps 100% do like our daily prognosis notes absolutely need a co-signature versus I know like just if we're checking in on a patient, throw a 2-second note in there. Those don't. But what are things that absolutely need cosigns and what don't?
So as far as ACS rounds, trauma rounds, all that goes, those are all going to have cosigns or attestation statements added daily.
And that's
when it comes to
the rounding attendant.
When it comes to being on the orange service, we'll just have to discuss that further.
So I think his question may be that Granny falls out of bed at 2 o'clock in the morning, they go write a note on that patient in Epic. What are they supposed to do with that? They need to send that to an attending to sign it, or?
Only if it's a billing.
I don't think if it's just like an update progress note, like a little interval thing, I don't think you have to have that cosign. That's just like an update in the chart.
I think you can see those.
If you put
the notes section, and you can, if you want to, you can click on it.
Yeah, you can. I mean, but I don't think you have to cosign required on some of that
Yeah,
stuff.
that's a departmental decision, what you want to do in terms of resident supervision. If you need things set up differently to mandate it, let us know, but otherwise, it's whatever you guys want to do with in terms of resident oversight.
I had a question. I did a case yesterday, and when I went to the post-op orders and to sign my chart and all that, the nurses in the OR had entered this crazy diagnosis without even asking me. That had nothing to do with the case. And since the case had already finished, when I went to sign the chart, I couldn't edit that at all. I couldn't change that diagnosis. I couldn't take it away, so it stayed on the chart.
I don't know. I guess we'll just have to maybe ask.
Yes. Man with the answers.
I think in that case, when you're in the OR, and if you tell the OR staff what type of...
You know why? I figured out why. It's because they want it pulled up for us like this because we do critical care.
Right,
But
so the
I'll
way
pull it
you
up.
get past that is to right-click in the area that's
Arch is exactly the
in
same,
yellow,
so is everybody's.
and you have to select Make This Editable, and then it'll turn into a regular format. I'll create something so you guys can see that. So anything that's in Epic that's pulled directly from the chart, if you right-click on it and make it editable, you can write over anything that's there.
One final question, Steve. I know talking to some of the nurses, they're very familiar with the system now. They tell me they go into 10 different sessions, some of them, and they're very familiar with all the intricacy of the system. But how long are we going to have some sort of support for us around here? I hear some of the fellows saying 2 weeks or something. Is it going to be an ongoing support to more limited basis? Do you know?
You know.
So over the next couple weeks, the amount of at-the-elbow support will be stepped down each week, and depending on how each clinical area is doing, some that are doing better will remove the support sooner. Those that are still struggling will provide more. We have a physician that's sitting over in the computer lab at the College of Medicine from 8 to 6 almost every day this week and next, who's very, very good at working through physician problems with us. So anybody that wants to spend time, go drop by. I heard the other day somebody spent 3 hours there. You're welcome to do that if you have that kind of time. If you just need a few questions and need 10 minutes, it's probably a good investment. As far as ongoing support, we have a large team at Erlanger that are our permanent employees, and they will be here long term. So the short answer is there will be some level of support forever, but certainly not the army of people wearing vests.
How long is the army of people going to be here? I'm sorry, I didn't hear that.
They're projected to be, some of them will be here for 4 weeks.
Okay, all right.
Are your permanent employed physicians or helpers or whatever, how do you contact one of those people when the 3 weeks of little red vest disappear?
I will still be here for helping you guys from now until my contract is February, from what I understand right now. I'll give you guys my email address.
All right. So we're running out of time, but last quick thing. I do want you to know that you can, so that we're not going to go over how to do this, but you can remote in from your computer at home, your laptop. You can dictate with your phone into Epic. Those are all things that you can do. There are apps for your smartphone and for your tablets. So those are all things you can do and get with one of us to get that set up if you want to, but there are things that are available.
We're going to go ahead and end. I'm sorry, we keep going forever. Quick.
Don't forget that you still have medical records in Physicians Portal or Envision. I looked in there yesterday and I had like 80 charts that I had to complete in the old system. So don't forget about
Okay,
that.
there are old charts that need to be fit. But I just talked to Brent. We're gonna try to do this same thing next week, Steve. Same time, same place. Mike.
Residents, please stay.
Let me just say that I understand watching the residents, I realize this is boring for you all. Let me tell you, watching you guys operate sometimes is boring for us. Believe it or not, I know that's hard to believe. So I expect you all to be here and participate in this too, because if we're ever going to make this thing work, we're going to all have to communicate with each other well. And so, no questions. What is it?
Residents, please stay.
Residents are going to stay and talk. Okay. But we're going to do this again next Wednesday, and so bring your questions or problems. We'll try to work through them.
For anybody that has time left this morning, Dr. Little is here from Epic. He's available all day. So if anybody wants to work with him, he's here and more than willing.
Yeah, we're going to talk about resident-specific issues, how to get the work done here. And I see there are no 8 o'clock OR cases in the main. Is that correct? Are there any 8 o'clock plaza cases? No? Okay, so we have a little bit of time. So first thing I want to say for the residents is there's a doctor named Zach Connor, and he is an Epic implementation person, and he's over in the Whitehall building, Suite 108, and I think he's there from 8 a.m. to 6 p.m. every day. I went over and spent about 5 hours with him yesterday. He'll help you personalize things to make it faster, but then he can also help you just understand how to get the work done. And he was actually very helpful. He was receptive to working with residents, which some people are not. So he was very helpful in that standpoint. And so if you're not doing anything today, you should be over there in Whitehall 108
on the computer figuring out how to do this thing better because it made my life much easier. On Monday, I was ready to kill people, literally.
What's his name?
His name is Zach Connor. I'll Tiger text out his cell phone number to everybody. But he's very helpful. You can call him anytime. This is what he's here to do, is help physicians use Epic. So a couple issues real quick. Kevin's going to start.
This will be very brief. One thing that we went over in training that did not happen over the weekend is how to appropriately respond to a consult placed by another service and or the ER. If you go under the Consults Physician tab under the Baroness folder, scroll down to General Surgery.
Write this down, people.
This shows patients who have current outstanding consults placed to a general surgery service. So like, I know this patient has been seen, but this consult order has not been satisfied because the notes were not done properly. When you open this patient's chart and you go to your pre-op consult tab, even if they're not going to the operating room, you should still be using the pre-op consult tab. When you scroll down, instead of going to the right H&P section, you need to be going to the consult notes section. Then when you hit create note, it brings up a box here that shows the general surgery consult order that's been placed by the consulting service, and you need to check the box to indicate that this note that I'm writing is there to satisfy the consult order. Does that make sense?
Otherwise, people don't know that we've done the consult. So we're going to go back to the beginning. We're going to do that again. Yeah.
Well, I'm not going to do that under my name, but I think you can just cancel the order. There should be an active order for consult to general surgery.
I don't like that, but I don't know what else to do.
I don't know what else to do.
Is there
either.
any Epic people
They
all
all
left? See, that's the kind of Epic support we're getting from a resident standpoint.
Yeah.
That right there. That's a perfect example.
Seriously though, Zach Connor, life-changing. I'll do that one more time. You find the folder, General Surgery Consults. You open the chart, pre-op consult tab, click the consult note button.
And that's where your H&Ps from the ER go.
Yeah, if you're in, this is how you should do it. But if you want to be contrary, then you can hit new note.
Yeah, well, that's the thing about Epic. There's 10 ways to do things. That's good and bad. So there's multiple ways to do things. So we're just trying to show you one way to do it. Because
if you title it consult note instead of H&P, yes, that box will pop up also.
You can change the title of the note from H&P to consult. Correct.
Yes.
Correct.
Always, regardless of whether they're actually going to the operating room anytime soon.
Yeah, there are a couple of the residents that when you click the cosign required box, the cosigner blank does not show up. So if that's an issue for you, then contact one of the Epic.
Show them how to do that on the ticket. So to create a ticket, this is what you do to create a ticket. You go to the EHS intranet homepage. Everybody recognizes that. And down on the bottom right, you scroll down to physician links and you go to eChart support ticket. If you have an issue that we can't fix, do that, and that issue is a work order.
How are the notes working so far that we've made?
We've made lots of changes.
Yeah, Kevin and I spent some time yesterday. So important things. The review of systems has to be filled out, and there's a note writer tool for that, which I didn't really understand until yesterday. Kevin will show you that here quickly. So as you're creating an H&P for this patient, if you're going to do that,
consult note.
Yes. You type .utsurg, and that pulls up all of our smart phrases that helps to pull up a template. Go up to the top, click on the top left, and hit F2. You select the service, blah, blah, blah. And as you F2 through things, it tells you what you have to do. Triple stars, you have to do. It'll stop there. Medications, social history, review of systems. So this is what we've done. There are 3 stars at the review of systems. That gives you a hard stop. When you get there, you go up to the top left underneath my note right there and it says review of systems. You click that. And then it gives you a nice little form where you can clicky box through and do the review of systems. You know, if you do 10 systems negative, click 10 systems are negative. You know, there's this all other systems are negative. I guess maybe you could do that too,
No, you have
but
to
I would not
click-
recommend
You
that.
have to click 10 different systems.
Yeah. And then it has, you know, positive things. So that's how you do the review of systems. That has to be done. Otherwise, it doesn't matter how complicated your note was. They don't get paid for it.
Yes.
So then you have to go back and take your wild card out?
Yes. And then as you're doing that, it puts it all in there, and the 3 stars have to be deleted. There's no other way for us to make it a hard stop so that people have to do a review of systems, because multiple notes over the weekend did not get a review of systems, and I'm sure at some point you will hear about that. Yes, and you'll hear.
No.
That's what we just said. You have to click the boxes.
My question is, are we allowed to just click the negative box? Because I thought
Yes.
in the training we were talking about, we had to like.
You have to click the negative box next to at least 10 different systems. Yes.
There is if you go over to that guy, Kevin, there is a way to like make it where all the systems are negative. No, there is a way on the note writer to do that from what they've told me. And I don't know how to.
We'll work on that, and if there's a way to streamline that in the future, we'll try it, but just do it this way for now.
I mean, it's still pretty streamlined. I mean, you just
It
click
is.
the boxes and it populates it. I mean, it's not too bad.
Yeah, do not check that box unless you have checked 10 individual systems.
Yeah. Because that's like, there's like 20 systems.
It just adds this blurb, and this does not satisfy, if that's all you have in there, that does not satisfy the billing requirements for a review system.
It takes 2 seconds. So the next F2 you'll get is
Oops, not that.
physical exam. Same thing. There's a tab right up there.
This tab or this tab. Both
Note
tabs.
note writer will pull up, and then you can put in your physical exam a little bit easier, we think. But if you don't like that, delete it and type in your physical exam. It just has to be accurate.
I've also heard some complaints about these systems not being complete enough. If you want more details about a system, you choose the appropriate tab across the top, such as the abdomen.
And you can draw a picture.
You can draw pictures and or choose other things.
No phalluses, please.
Yes. Rooks' H&P from the other day that I attested to was very special.
No, I'm not.
Okay. Yeah, Capote.
So when we get a consult from the ED, we get a page. So we have to look up the patient to make sure that there's a consult order that we can satisfy.
There should be. That's sort of part of their workflow.
Yeah,
That's how they
I mean,
consult us now.
There shouldn't be any patient that you get consulted in the ER that doesn't have a consult request.
In the same way, if you're placing a consult, you need to be putting an order in the system as well. If you're
So we're going to go through that right now.
Consults go, there is an order, and there still needs to be a phone call.
Yes,
They will still, they should still page you. That is from medical executive committee, that there is still a phone call being initiated for consults. It is not a, I'm putting this in the system and walking away. And
So
that
here-
should not happen from our department. Okay, so just call, make a phone call.
So to put in a consult in the orders section, you can search for whatever. Like that was neuro. There's also consult, and
Sorry. Here's something that's been confusing people. When you search for orders, it brings up your preference list. This is not all the orders in the Epic system. A lot of times you need to click the facility list box, and that brings up a lot more options.
yeah.
So if you can't find something, it's probably because you're on preference list instead of facility list.
and that almost led to the end of another keyboard on Sunday.
Yes.
So this is how you do it, and then you click on the console, like consult cardiology for this patient, okay? And that creates, and you put the reason for consult and all that kind of stuff.
Does it bring up their phone numbers now?
No, you don't have to.
So we're still calling the consult service to physically talk to
Yes.
someone, and then we just have to say there is an order in the chart for this patient.
They should
Well,
know.
that's
to do that,
implied.
yeah. It's implied.
Just want to tell them what you're calling the consult in for, and that's it. I'm calling you a consult for elevated troponins or whatever, and then you don't have to tell them there's a consult in the system. I mean, if you want to, that's fine, but there should be one already there.
Kevin, can you show face sheets?
I don't know how to do that.
Okay, well then go to summary.
Why do we need a face sheet?
Oh yeah.
Yeah, orange race, yes.
Search box to the right, type
Okay, that's good to know.
You can also, if you want to keep it, hit the wrench and add it, scroll all the way down and type in the face sheet. It will add your...
That goes up here?
Yes.
Okay.
And so if you scroll down, it will tell you your
Okay.
insurance information, although there's a lot of very socially orange patients that seem to have adequate insurance, so I don't trust it.
Hey, do you know if that is putting their auto insurance in on trauma patients in that tab?
Are they putting auto insurance in?
They should,
No, I don't know.
because they built it that.
Interesting. Okay, that's good to know.
Well, no, we're having a problem in the office on how to identify that. So, I mean, these little things like that, they are going to be instrumental as we discover them. Unfortunately, that's going to be a process of discovery here over the next years.
A few more very short notes. If you're doing a procedure sticker,
yeah.
central lines, chest tubes, bronchoscopy, etc., when you go to the Notes tab, typically you're hitting New Note to use one of our templates. Instead, you need to click the second button that says Create in Note Writer. Then, when you select your note type, you hit Procedures and Bedside Procedure Note.
These all should have a cosign with an assignment on those, correct?
Then you can choose your appropriate procedure, let's say a central line, and you click through all of your appropriate boxes, how your consent was obtained, risks were discussed, what you did, what you put in the patient, etc. It kind of nicely, it just has some general click boxes, and this is what's replacing the procedure stickers.
Yeah, this is your sticker.
Any questions about that?
What does it say authorized by Alvae?
I don't know.
Is everybody's different, or does it all say Alvae?
No, you can change it.
I just logged into that.
Ah.
Yeah.
Okay.
That value maybe get some serious work, it sounds like.
This is a VIA patient, isn't
It's
it?
not
That
going
is
to
a
go.
VIA patient,
This is a
yes.
VIA patient.
So that's that's who the patient is
Okay. All right.
admitted to, or the surgeon that they're attached to.
Two more things. I had several of you create signatures during training that included your pager number. This is a really good idea. Instead of just doing the .me, we'll just put your name in it. I would encourage you to create a signature that has your pager information so that other services can contact you that you're, once you're involved with that patient. I would also like to strongly emphasize that when you're finished with the terminal, a computer, that you hit the log out button. I think a lot of us are used to just getting up and letting the system log you out. That doesn't work anymore because it completely locks the computer and no other users can use it until you come back to that workstation and log back in.
Don't X out, log out.
Log out. Dr. Spiegel.
I've had, on Monday when I was on A, I've gotten a lot of pages of services because when you're on the notes section, it just says general surgery.
That's all that exists.
Exactly. So is there something that we can at least spread around to the other services that says to look at the actual note, see what service is actually in this patient's care, and then, I guess, adjust the note to say ACS and then put the ACS.
It says it at the top of every note.
I know, but they don't know.
That's what the green sheets, that's been that way for 6 years. The green sheets have always said the service on top, and they never read them. I don't know how to change that. If
Put
anybody
your
has any
personal pager in there.
suggestions.
Or at least put each service's pager number next to general surgery.
Yes. So no,
We're working on it.
We have figured out a way to do that. It is in a horrible format that'll make it like 8 times as long. So we can discuss that later, but it looks like terrible.
Cultures.
Yes.
Yeah.
A hard stop for cultures. It forces you to look at it. And I think that's probably how we're going to keep it because it's not, it looks terrible. I think those are all my things. Please just remember that if the attending says, hey, you're going to dictate this and you're responsible for documenting on that patient's operative report, you don't have to do both a brief op note and an op note. If you're going to use Epic to chart your full operative report, then you do not have to do a brief op note. That's a change because before you'd have to fill out the green sheet and dictate. Now your one full operative note counts for everything.
That is true. There is one caveat on the brief operative note. It has a tab there that the attending that makes sure that you put the attending was present or available or whatever. If you don't do a brief op note, that has to be in your operative report somewhere.
We still dictate those the old
You can dictate it that way, but make sure that that statement is in the operative note. If it is not, it's a legal issue.
Okay, I think that's.
I'm adding attestation statements to your operative notes personally to make sure that that's in there. I'm not sure that's going to be everybody's practice, but we'll talk about that at our business meeting.
Yeah, because you all have to sign all our op notes, correct?
Yes. Yep. And I'm like I said, I've been adding attestation statements with that in there.
We're still dictating discharge summaries anyway.
Incorrect.
What was the question?
Discharge summary.
Oh, yeah.
So if you're going to discharge a patient, like this patient, you go non-surgical, and then up here you've got tabs. This is how you transfer patients. This is how you discharge patients. When you go to discharge, one of the in the table of contents here, so I don't have to scroll through, you can see discharge summary. And this actually, when you click it, it creates if you created a note on this patient, it actually pulls in a lot of the information that you don't want to have to dictate. So it pulls in who the attending was, blah, blah, blah.
Fantastic.
We've set the place on fire. It even pulls in the procedures, so the operations that they have will be in here. And then test results, it's kind of this formed thing. And then you can dictate, use your phone or type or however you want to do it in the hospital course and things like that. Please note, though, that there are the last vital signs are in here. Like I saw one patient that was discharged yesterday whose discharge blood pressure was 186/94 or something like that. So just keep that in mind when you're discharging somebody. Maybe address it in the notes. I think you can just delete it. That's true.
The sprinklers will now come on to make this as miserable as possible.
All right.
Thank you, guys.
Yeah. Yes.
So discharge summaries, like, do you have to do a discharge summary for someone that's only 23 hours?
No.
Okay, you don't have to do that. And what about trauma? Are we doing
From what I have been told, the discharge service is still doing the discharge summaries for trauma. That is yet to be seen.
All right. Thank you, guys.